Good morning. It's 8 a.m. of day 2 of the scientific sessions of the American Diabetes Association. It's my honor to chair this session entitled the American Diabetes Association Diabetes Care Symposium, The Final Frontier, Implementing the Learning from Implementation Science. The idea for this symposium came about through the efforts of the editorial leadership team of Diabetes Care, led by Dr. Stephen Kahn, with myself, Liz Selvin, and Cheryl Anderson. Last year, our symposium was focused on health equity, one of the great barriers to consistent, better outcomes in patients with diabetes. And this time, we thought that implementation science really is a huge opportunity for the care of people with diabetes. There's so many things that we know work, but they're inconsistently implemented nationwide and globally. So we're going to have 4 presentations of 20 minutes each, and the fourth one will be a bit of a wrap-up. If everything goes according to schedule, we'll have about 10 or 15 minutes for questions and answers at the end. So first up is Dr. Brian Oldenburg. He's a professor of public health and implementation science at the Baker Heart and Diabetes Institute in Australia. He's the director of the Australia Connected Health Centre of Research Excellence in Digital Technology and the director of academic research collaboration in health at the Alfred University Teaching Hospital. He's a behavioral scientist and chronic disease epidemiologist by trade, world-renowned PI and co-PI of many, many studies in the past, and look forward to hearing his talk entitled Diabetes Prevention, What Do We Know Now That We Didn't Know 20 Years Ago? So Brian, why don't you come on up? I forgot to say one thing. So photography is at the discretion of the presenter. Are you okay with photographs? Sure. Yeah, so feel free to take photographs.
Well, photos of me or them?
Both.
So thanks very much, Dr. Buse, for that very kind introduction, and thank you so much for the ADA meeting organisers for helping me to get here. Firstly, I'll spend a few minutes just overviewing what myself and the other presenters are going to talk about and the sort of lens through which we're looking at these presentations. And I'd like to firstly just mention that when I was on the Lancet Commission for Diabetes a number of years ago, it was published in the Lancet in 2020, when we looked at the evidence for action and implementation globally, you know, the obvious conclusion we reached was, you know, we know a lot, but we don't do very well with implementation. So, you know, this global challenge of implementation is, we're arguing this symposium today is really one of the major challenges for doing a much better job for our patients and for improving diabetes and diabetes outcomes in defined populations. And the majority of people who are at risk or who already have diabetes still don't perceive what's really recommended in the evidence-based guidelines. And this is really the focus of the paper, which is being published in Diabetes Compare, the current diabetes care issue, and I understand the embargo on this paper was to be lifted, John, at 8 a.m. this morning. But
supposedly,
yeah. So it's available for everyone to read. And the essence really of it is that, you know, we know a lot about what to do. However, the challenge is really how to translate those research findings into healthcare delivery, to policy, into community programs and services in order to maximise benefit, not just for a small number of individuals who are clearly the most motivated and become involved in programs, but to the broader population who are impacted by diabetes globally. And in particular, and John's already alluded to the point about equity, you know, how can these programs be accessible and taken up and adopted by those who typically have poorest access to health services and or who are vulnerable and disadvantaged. So this no-do gap, which it's often referred to, it's this question really in the middle. How do we go from the no to the do, and to do this in scalable ways? And in the publication, you'll see when you look at it in due course that we talk about this failure for implementation, and then we, in each of our areas, we identify the importance of particular barriers and what might be effective strategies, evidence-based strategies for implementation science to address those barriers in order to have more impact in the real world and at a population level. So this researching how to implement is informed by the new field of implementation science, and I put the new in inverted commas to make the point really that it's actually not a very new field. I think maybe it hasn't impacted as significantly and as widely as it could and should have throughout health and healthcare delivery. And in fact, you know, NIH has been funding programs in implementation science for about the last 15 or 20 years, and there's a special study section on implementation science. But there's really three major sort of themes to research in the field of implementation science. It's about how to adapt programs and services to different cultures and contexts and populations. And typically, as we'll come to see, I'm sure in a lot of the examples presented today, that what's actually adapted and how it's adapted and what it looks like and the delivery systems end up being quite different to probably what was evaluated in the controlled trials. Understanding barriers and enablers is a key focus, and then developing strategies to address these. And the key point about implementation science, I think, is the importance of context, understanding the context, the populations, the services, you know, the socio-cultural features of different populations, and then adapting the programs to those different populations. And in the sort of amongst my colleagues in the field of implementation science, they often talk about content being really important and the curricula of a program. But what's really important is the context, because if you don't understand the context, you don't adapt to the context, then it doesn't really matter what the content is. Its adoption and implementation is likely to be very poor. The translation pipeline from basic research through to implementation, scale-up and populations. Implementation research takes methods and approaches adapted from many different fields and backgrounds, but the point is that the kinds of study designs tend to be more pragmatic kinds of trials and hybrid designs. And by hybrid designs, I mean studies which give an equal focus to measuring outcomes and effectiveness, which is important, but just as important and often more importantly, understanding kind of what's in the black box and understanding process and implementation. And in the paper, we then have a lot of discussion about the different sort of areas we focus on in terms of prevention, glycemic control and complications, and look at the evidence gaps for implementation and propose strategies for addressing these. So coming now specifically to my presentation, diabetes prevention, what do we know now that we didn't know 20 years ago? I'll talk about what we know, and I'll do this very briefly, what we know about implementation, scalability of diabetes prevention using structured lifestyle intervention programs, and then secondly, what have been some of the learnings we've derived from the work I've had the privilege of being involved with in India for the last 15 years. Now, the landmark efficacy trials, I'm sure most of you are pretty familiar with these. These have really demonstrated pretty impressive outcomes in terms of reductions in diabetes incidence between 30, 60, 70% across the different trials, long-term outcomes for at least 3 of the trials, some pretty good maintenance and positive long-term outcomes, including lower all-cause mortality, and then also demonstrating cost effectiveness in short to medium term and potentially cost savings in the longer term. So good evidence from the efficacy trials. Once we come to more real-world effectiveness, there the picture is rather more mixed. And typically with the real-world effectiveness trials, which have adapted the US Diabetes Prevention Program or the Finnish Diabetes Prevention Study kinds of interventions to more community settings, typically the inclusion criteria for participants have been broadened. They've used other delivery methods, digital delivery. I'm going to talk about a peer support program in India and lots of other creative ways of delivering programs to participants. They've also been delivered in many different community settings, in workplaces, YMCAs, churches, general community, and so on. And the other interesting feature of these real-world effectiveness trials is a lot of them have moved away from having PhD trained nutritionists to deliver programs or whatever, which was the case with the Finnish diabetes prevention study, because that's never going to be scalable. But they've then trained lay people and community health workers to be more involved in the delivery of the program. And importantly, that many of them have used hybrid implementation effectiveness designs. So the good news, one meta-analysis of these studies demonstrated some reasonable improvements in terms of weight loss, some evidence of maintenance regardless of whether the intervention was delivered by health professionals or lay people, and then a global systematic review also showed some reduction in diabetes incidence as well. The sobering news is, as you might expect or predict, the sort of voltage of drop in terms of participation rates from community tend to be only modest. Implementation outcomes have often been pretty poorly measured, so it's not, in many of these studies, when you look at the reporting of them, often hard to know exactly what was happening inside the black box. And most of these real-world implementation trials, although this has changed a little bit in recent years, have been conducted in high-income countries. I just want to make the point that program intensity is important for the weight loss outcomes, but I had a student a number of years ago, Zara Aziz, and she conducted a systematic review of all of these prevention programs and made the very important point that we don't actually give enough attention to reach and adoption, because if you can get very large reach and good adoption and uptake of programs, even though the intensity might be less and the weight loss outcomes might be less, this can still be an impressive outcome in terms of population benefit versus just the individual benefit. And we've known this for many years, that reaching large numbers of people is important for achieving population benefit and getting wider adoption, good consistent implementation, and production of replicable and long-lasting effects. So then we ask the question, well, if we kind of go from those still semi-controlled real-world implementation trials and go to real scale at whole populations, country and regional level, what do we know there? And, we don't actually have a lot of good results to go on. And of course, these are not controlled studies and investigations. So hence the importance of understanding implementation and process to try and understand, what the causality chain might be. But from the NHANES data, less than 5% of eligible individuals are probably being referred to a lifestyle intervention program. Less than 30 or 40% of those are actually going to participate in anything. That being said, the NDPP program has reached a large number of people in the US population. In the UK, with their national NHS diabetes prevention program, probably upwards of 300,000 people have participated in that program, but only a third have attended one session. So the evidence about going to real scale at a whole of population level is mixed. I suppose the question that, that sort of begs the question, are these results low or good from an implementation perspective? Because you may well say, okay, the uptake and the participation rates are low, but in another sense, this can still be a large number of people. So maybe the more important question is, who's actually taking up the program, and are the programs actually getting to the people who might derive most benefit, particularly those people who are most vulnerable and disadvantaged? So my remaining time, I'm going to shift focus and talk about India and talk about research we've been doing there over the last 15 years. And I'll use the sort of royal we term, but this is very much in collaboration with the colleagues in the institutes, the centres, the state health departments we've been working with there. And as most of you may well know, the NCD epidemic in India is a huge challenge in all respects. Rates of diabetes, hypertension, obesity have all really escalated in recent years. So the kind of gaps in implementation of care and prevention are extremely challenging. So the importance of deriving or looking at the evidence from elsewhere in the world and how that might be adapted and implemented in that context with populations there is what we've been focusing on the last 15 years. We've mainly been working in southern India, in the state of Kerala, with an institute there called the Sri Shivra Tirunal Institute. More recently with CMC Vellore, with the National Institute of Epidemiology as part of the Indian Council of Medical Research, and also with the Kudumshri mission, which is a very large NGO in Kerala. I'll come back to them later on. And then in the last 5 years, and particularly since COVID, we've worked very closely with the Kerala and Tamil Nadu state governments, and these are two states that have a combined population of about 140 million people, so large populations to work with. So the Kerala Diabetes Prevention Program, we started the development of that about 15 years ago and went through a sort of careful set of stages. Fortunately, we've had really terrific funding for this program over the last 15 years from various sources, including NIH. So we've been able to systematically look at needs of populations, culturally adapt programs, particularly the program from Finland, DPS and DPP, look at implementation, look at outcomes, cost effectiveness, go to scale with almost 400,000 people in 40,000 communities throughout Kerala, and then also look at long-term effectiveness. So I'll kind of briefly come to some of these points now. The Kerala Diabetes Prevention Program really rests on an adaptation of a community-based peer support program in local communities, led by a leader chosen by the group of people with high risk of diabetes. The program comprises 15 sessions, and what's been one of the most interesting features of our research over the last 15 years has been the fact that a lot of the action has actually happened outside the groups. In a sense, the group has been the stimulus and empowering the leaders and the people in the groups to not only do things that might be healthy for them and to reduce their diabetes risk and change health behaviours and so on, but they've also initiated a lot of other changes in their communities as well. So we've referred to this as the ripple effects of the program going off, or spin-off activities from the core program. The outcomes, just in very briefly, these have all been published. The overall incidence of type 2 diabetes was just under 15% in the intervention arm and over 17% in the control arm, a non-significant difference, but a trend nevertheless. And there was a significant reduction amongst the group who were IGT at baseline, and this was reported as a post hoc analysis. There was a significant reduction in the Indian diabetes risk score. Intervention participants more likely to make changes to diet. more like those who were consuming large amounts of alcohol at baseline, more likely to reduce alcohol consumption, other changes in some other health behaviours and risk factors. The absolute risk reduction in predicted 10-year CVD risk between the study groups was significant. This slide, these results are preliminary, and these are results at 9 years. So we've been very fortunate in getting a grant to look at the 9-10-year follow-ups. So again, still showing an advantage to the intervention participants compared to the control participants after 9 years. So that's after the horrors of COVID and other things that have happened in Kerala State over the last 10 years. Cost effectiveness, cost effective from a health system perspective and a societal perspective. And the implementation outcomes, we've been able to demonstrate really good implementation of the program, and the implementation outcomes have been terrific at the individual level of the participants, the level of the leaders, and also at the community level. Good attendance at the groups and good attendance or involvement of most of the groups in those other ripple or spin-off activities that I mentioned a couple of minutes ago. As I say, we're just doing the 9-year follow-up at the moment, so we'll look more deeply at the results in terms of diabetes incidence, cardiovascular risk, cost effectiveness, and so on. So about 6 years ago then, as the results were coming out from the main trial, we turned our attention to look at sustainability and scale up of the program and how it could be further developed for scale for diabetes prevention, but also how potentially the kind of model could be adapted to diabetes management and management of other chronic conditions. So the scale up was conducted in collaboration with a very large NGO in Kerala, which I mentioned earlier on, called the Kadumshri Mission, which is a very large family-based NGO in Kerala, southern India, existed for something like 50 years, involved in poverty eradication programs, child and maternal health. This was their first sort of initiative in the sort of area of NCDs and chronic conditions. So that was the organisation that took on board the training of all the leaders and the implementation of the program. So it moved into the community from the institute who we were collaborating with. And it was scaled up through 3 areas of 3 districts or region of Kerala, about 15,000 peer leaders and over 370,000 participants. Some evidence of reduced CVD risk. This wasn't run as a trial, so we had to kind of impute the results from other data and information that was collected. Then in the last 3 years, it commenced late 2019, early 2020, which wasn't a great time to start a community-based trial in India, so it was put on hold for about 3 years to look at adapting the KDP model to improve management of hypertension and diabetes throughout the states of Tamil Nadu and Kerala. And this project is ongoing at the moment, very close collaboration with the 2 state governments of in those states. So then what have been the learnings? And I like to think of these as potential reverse innovations. So what can we learn from the work that we've been doing in India for the last 15 years that might be relevant and of interest to countries like ours, the US, Australia, high-income countries? I think what we've been able to demonstrate that peer leaders, people trained from local communities, can do a fantastic job of implementation. They're engaged, they're involved, they're connected with their communities, and they can also work really well with local resource persons. And we've been able to demonstrate great implementation and pretty good outcomes. The partnerships for implementation and leadership between government and research institutions and the community organisations, key and central, not possible to do very much without those. And yeah, getting the state departments involved, getting their attention and their involvement has been really terrific, particularly the last couple of years since COVID with the larger program in those two states. As I say, at the core of the program are the peer leaders, because they're the ones who really provide the stickiness for the program and in the local communities, and really work with the other participants in their groups to make change. So I think this power to empowerment model we've kind of written about and talked about, I think is important. It's important for the participants, important for the leaders, and important for other people in the communities to be associated with the program. Implementation science learnings, international funding and strong collaborations and partnerships have been great. Implementation science methods can really generate findings that can then inform further adaptations, improvement and developments of programs to make them more sustainable and scalable. And then implementation science methods can also generate findings to inform adaptation and transfer to other context settings and countries, which we've been doing elsewhere in Asia and sub-Saharan Africa. So with that, I'll finish. I'd like to just formally acknowledge all of my collaborators, colleagues, students, and all the funding we've had. We've had a fantastic group of early, mid-career researchers, students who've been involved from India and Australia in different aspects of the research. And then, all of the colleagues and collaborators in India that have really made the work possible. It's been a very exciting collaboration partnership for 15 years. Thank you.
Thank you. That was outstanding. So the next speaker is Dr. Matt Crowley from Duke University. He's an associate professor of medicine with tenure, a staff physician at the Durham VA Medical Center, and a core investigator at the Durham VA Center for Health Services Research. He's an expert in clinical diabetes care, a prolific health services researcher, a great educator, I understand a great doctor too, and a good friend from just 12 miles up the road. He's funded through the NIH and the VA, and leads their T32 training grant in endocrinology. And Matt is going to talk to us about using telehealth to improve diabetes control in real-world practice. Take it away.
Thank you, John.
Now remember, if you want to use a pointer, you have to point.
Just making sure I've, there we go. Okay. Well, thank you so much, John, for the introduction, and thanks to Diabetes Care and ADA for this symposium kind of centering implementation research, which I think, as Brian eloquently explained, is really critical to seeing real-world impacts from a lot of the research we do. Here are my disclosures, or lack thereof, my current research support, and then I actually have no conflicts of interest to disclose. By way of overview, just to level set here, I want to start by talking a bit about the limitations of in-person care for glycemic control. Move on to talk a little bit about comprehensive telehealth as a means to improve glycemic control in cases where in-person care doesn't prove effective. And then wrap up with a discussion of some barriers to real-world use of comprehensive telehealth and how we might approach those. Note that I said approach them, not solve them, because these are ongoing challenges. And then we'll wrap up with some conclusions. So when we talk about glycemic management, there's an audience that's very savvy about this, probably don't need to explain this too much, but achieving recommended glycemic targets in type 2 diabetes really calls for holistic management. Now, a quick look around our ADA conference will make it very clear that medications are central to that. 75% of people or more take at least one medication for type 2 diabetes, and in fact, the use of most medication classes for type 2 diabetes has increased in recent years, some more than others. But at the same time, behavioral interventions like nutrition therapy, physical activity support really provide valuable glycemic benefits as well, and both are extremely important. In particular, I want to call out the strong evidence base supporting diabetes self-management education and support interventions as a means to effectively deliver behavioral content. But at the same time, all is not well, because despite the existence of all these effective therapies, many of our patients and people across the world are not meeting ADA recommended glycemic targets. drilling down on folks with type 2 diabetes here in the U.S., 10 to 15% of all people across the country with type 2 diabetes maintain a hemoglobin A1C above 8.5 despite engaging with diabetes care. So when I give you these numbers, I'm not talking about people who are newly diagnosed or people who are not interfacing with the medical system. These are people who are receiving care but remaining poorly controlled. And this sort of lack of response to available care can relate to a variety of factors, including non-adherence to recommended self-management, therapeutic inertia, and difficulty accessing care as well, even for people who are plugged into this system. In some areas, endocrinology care is not widely available. DSMES interventions are known to be widely underutilized, and some people have difficulty connecting with those. When we talk about what drives these elevations, persistent elevations in hemoglobin A1C, what I think it boils down to is the fact that diabetes self-management is really complex. In what other chronic disease state do we ask people to take medications multiple times a day, often via injection, to sometimes check their sugar via finger stick or via continuous glucose monitor frequently throughout the day, to time their diet and their exercise around medication taking? Looking at other chronic diseases, diabetes is just an order of magnitude more complicated to self-manage. And in terms of understanding how patients navigate the burden of diabetes self-management, I like to think about this model created by Nathan Shippey and colleagues called the cumulative complexity model. And really what this states is that elevated A1C can result when the demands of diabetes self-management exceed a patient's self-management capacity. This is a model that's created to describe chronic disease engagement in general, but I think it works really well for type 2 diabetes. And I want to make it clear that demands of care or self-management and then patient capacity, these are not static factors. They're determined and influenced by a variety of factors and conditions. For example, the demands of care may vary with the medication regimen prescribed or medical comorbidities. And then patient capacity is clearly affected by a broad range of factors, including social drivers of health, access to education and support, et cetera. So, based on this model, when the demands of self-management exceed self-management capacity, elevated A1C follows. And then to take that a step further, when the available care that a patient can access, which for most folks entails intermittent in-person care, when that fails to improve or address this balance between self-management demands and capacity, that elevated A1C can then persist over time. And these episodes of persistently elevated hemoglobin A1C are really a problem because they leave patients at unacceptably high risk for complications and costs. And for folks who have persistently elevated A1C, despite receiving the care that's available to them, really something else is needed. And the question I'm here to ask is, can telehealth help with this problem? So what is telehealth? Well, telehealth is something we're all, I'm sure, familiar with to some degree, but the idea is that telehealth provides remote delivery of evidence-based care and facilitates more frequent patient-provider contact than in-person care can realistically achieve. Telehealth leverages communication technologies to gather patient-generated health data, which are then used to support delivery of remote care. And telehealth can be particularly valuable for rural patients and others with limited access to in-person care. Now, you might be asking yourself, didn't the pandemic already increase use of telehealth? Why do we even need to talk about this? Well, if you're thinking that, my answer to you would be yes and no. Because while the COVID-19 pandemic definitely drove an upsurge of remote care utilization in the US and around the world, here's the thing with that. The pandemic-style telehealth we deliver, and that's a term I like, pandemic-style telehealth, really what we're talking about are intermittent appointments conducted remotely at really the same sort of frequency as in-person care. So pandemic-style telehealth has all the same limitations that in-person care does for this group of folks that doesn't respond well to that mode of care. Margaret Zupa and Anne-Marie Roslin from University of Pittsburgh demonstrated this really clearly, I think, in a recent study that I wanted to share with the group. Let me move my pointer over here and see if this works. Can y'all see that? Good.
Yeah.
So this is an observational study that compared a cohort of patients receiving in-person care in the years following the pandemic to folks receiving telemedicine-based care. In essence, in this case, equivalent numbers of appointments, about 2 to 3 a year, conducted either in person or remotely. And not only was the telehealth group not better off than the in-person group, they were worse off in many cases, particularly for people who are using insulin, which is very common among this group of folks who are not responding well to clinic-based care. So what does this tell us? It tells us we really need to move beyond our current pandemic-style telehealth to something more comprehensive. And when I say comprehensive telehealth, what I mean are interventions that really capitalize on the advantages of the telehealth format to address multiple drivers of persistent HbA1c elevation. For example, these programs should provide frequent contact to help folks navigate the demands of diabetes self-management. They should provide effective education and support to bolster self-management capacity. And then on top of that, should help support evidence-based medical therapy through timely treatment intensification. And with these sorts of programs, we have the chance to then bring patient capacity and demands of self-management into a better balance and achieve better results. As an example of a comprehensive telehealth program that's been effective, I wanted to share a little bit about our work related to the ACDC program, or Advanced Comprehensive Diabetes Care. And Brian, I want to make it clear that this is totally unrelated to that fine group of Australian gentlemen on screen. Some of the key design features for ACDC that are worth pointing out are that this is a program that's designed to provide frequent contact in order to help balance self-management workload and patient self-management capacity, and then to combat therapeutic inertia. And then critically, we explicitly developed ACDC for delivery within the Veterans Affairs system here in the US by clinical home telehealth nurses using standard VA equipment. So because of this leveraging of existing resources, this has really made ACDC amenable to implementation and dissemination across the VA system. Just a couple words on the design of the program. So ACDC is primarily delivered by these home telehealth nurses in the form of 30-minute phone calls that are happening every 2 weeks during a 6-month period. There's 3 intervention components. There's a telemonitoring component where the nurse reviews blood glucose data, reconciles medications, reviews medication adherence, and troubleshoots any questions that a patient might have or issues they might be struggling with. There's a self-management support component then, as the second piece, where home telehealth delivers a self-management education module during most of the calls. There's 10 modules total over the 6 months. After that point, the nurse compiles a report using a templated note in the EHR, and then forwards that through the EHR to a medication manager who's also a clinical provider. And at most of our sites, this is a clinical pharmacist. The medication manager reviews the report, determines whether any medication changes are needed, enters any orders, and then forwards those back to the nurse for implementation. So there's no need for direct contact between the medication manager and the patient. And what I like about this system is that it really allows these nurses to function at the top of their scope, gathering data, working with patients, delivering education. And it also extends the reach of the medication manager to areas where, folks might not have immediate access to specialty medication management. Each of these components is designed to address one of the issues I laid out earlier. Now, thinking about that traditional kind of efficacy to effectiveness to implementation spectrum of research, we've done a fair amount of efficacy and effectiveness research related to this program. This is one recent trial where we, after showing that the program was effective versus usual care, did an active comparator trial where we compared the comprehensive telehealth ACDC program to a simpler program, sort of the standard telemonitoring care coordination intervention available within VA. And we found that the ACDC program was more effective. We saw a lot of improvements in other ancillary variables like diabetes distress, diabetes self-care, self-efficacy. Hypoglycemia rates were low, and then we did a detailed cost analysis looking at intervention costs and found that the cost difference between the programs was pretty reasonable and justified by the benefits. Now, taking this from then effectiveness into the implementation setting, we've actually been able to implement this program fairly broadly within VA. It's currently in real-world clinical use at 30 sites around the country. And, you know, as part of that, we've continued to do an implementation evaluation that's informed by the REAIM framework and have found that amongst other implementation outcomes, the program sort of retained its effectiveness in practice, and you can see that here. One of the nice things is that now that we've been doing this for a while, we've been able to track data out as far as 3 years or more, and a lot of the A1C benefit that accrues appears to be retained. So still some work to do to bring this to true scale within VA, but we're definitely on the right track. In fact, we have an ongoing implementation trial that's funded by VA where we're comparing a couple different implementation strategies for putting this program into practice, and that this will generate a whole lot of useful implementation data to help us bring it to the next level where this is a fully nationally implemented program. So that's a fun story, a success story. The problem is VA is kind of a unique system that has a lot of infrastructure that other systems don't. So let's pivot to talk about barriers to real-world use of comprehensive telehealth in other systems and then how we approach those. So there's no question that the complex nature of these sorts of programs really presents challenges for translation to some practice settings. And we are currently engaged in an NIH-funded study that I lead together with my colleague from the Duke School of Nursing, Ryan Shaw, where we're examining really how to feasibly deliver comprehensive telehealth in a fee-for-service environment, and that study is called Extend. This study has really presented us with the opportunity to kind of reflect on some of the barriers to implementation of comprehensive telehealth. So I'd like to run through some of those here. And I want to be clear, each of these barriers is probably enough for a lecture in and of itself, so I'm going to be fairly superficial in going through these. But again, the idea here is to give us some things to think about as we are trying to implement these sorts of programs in the future. So the first challenge is that a lot of the telehealth program designs that are out there are really reliant on research-funded resources and not well designed for translation to practice. The solution in this setting is really to center implementation from the very beginning of program development. And that actually involves a lot of important things like engaging partners from the community and other levels from the very outset of program design. So in the case of our Extend program, which is a comprehensive telehealth intervention that's based on the ACDC program, we really made a strong effort to build the program around existing clinical staff within our health system. We've tried to leverage tools and technology that patients will be able to access in the real world. And we've tried to avoid any kind of complex data management systems. Now, as you'll see in a minute, I don't know that we were totally successful in avoiding complex data management systems because data management is complex, but we tried. And at the same time, we also engage partners throughout our community in Durham, North Carolina. And community input was really important to finalizing our intervention approach, our intervention materials, and various aspects of the program. We also sought input from the health system, from providers, and then it's also important to consider input from payers and policymakers as well. So moving on to the second challenge, one thing we notice, even with a program like ACDC in a fairly homogeneous system like the VA, is that what works well in one context may not work in the other. As Brian put it, context is God, which I had not heard before, but I really like because it really is so true that what works in one setting may not work well in another. In our experience, what this really comes down to in terms of facing this challenge is trying to not only design the program around widely available staff and resources, like I said, but also explicitly defining core and adaptable components to an intervention. What are the core components that really makes the intervention, and where is there room to adapt? Where's there wiggle room? I don't expect you to read this slide in detail. This is from an implementation paper we did on the ACDC program. But I just wanted to highlight here how we have explicitly tried to identify core components and adaptable components related to a variety of factors, from the patient population to the format of intervention delivery to the delivery setting itself, personnel that are used, and then content-related factors like intervention procedures, intervention materials, et cetera. And this gives us some guidance as far as taking, an intervention like AC/DC into new VA programs, but is even more important when we're talking about moving something like a telehealth program into different health systems more broadly. Third challenge is insufficient electronic health record integration of patient-generated data. Something like a comprehensive telehealth intervention really relies on having access to patient-generated data for the care team. And while that infrastructure exists within VA, within our system here at Duke down in North Carolina, or up in North Carolina, I guess, the infrastructure is currently not there. So we've actually done a lot of work related to this issue as part of our ongoing R01, where we've really worked with our health system and our technology service to design an Epic integrated system for getting data from patients into the EHR. And again, busy diagram, don't expect you to look at the whole thing, but if you just focus here, what we've created is a system where data can flow from patients across these different devices through the vendor apps, and then into a data lake that Duke maintains, where it then can move and flow into the electronic health record and be used by our teams to drive the intervention. And this is a bit Duke specific, but in concept, this is something that any health system could do. Challenge number 4, uncertain reimbursement as a threat to sustainment. In a fee-for-service environment, if a program is not reimbursable, it's not going to be sustainable. And this is a tricky one, and what it really comes down to is understanding and leveraging available reimbursement in the target context. Broadly, there are many options for reimbursement of different types of telehealth programs across different payers. For Extend, we have an explicit study aim that's really geared towards comparing potential reimbursement strategies against intervention costs. To provide you all with some good resources for information on reimbursement, I would direct you to the Health and Human Services website. This provides a lot of summary information on policies across payers, including Medicare, Medicaid, private insurers. And then additionally, there's the Center for Connected Health Policy, which provides a lot of state-specific information on telehealth laws and reimbursement policies. Again, this is a very context-dependent issue, and something that you really have to understand in your context in order to understand sustainability. Lastly, I wanted to just mention the idea of decreased program impact in real-world settings. Dr. Oldenburg mentioned the idea of a voltage drop, which is a great term for this. Sometimes when we take things, whether it's a complex telehealth intervention or a drug, from an efficacy/effectiveness setting into the real world, we see that the effect is not quite what it was in the study setting. And I think what this comes down to is maintaining a rigorous implementation evaluation. For our AC/DC work, we use the REAIM framework. REAIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. It gives sort of a framework for evaluating the quality and completeness of the implementation of a program. And then for our ongoing implementation trial within VA, and then our Extend work, we are using the consolidated framework for implementation research to guide our implementation evaluation. CFR is a very commonly used framework these days, and provides a lot of great constructs and things to think about when you're designing your implementation evaluation, even as far back as intervention development. Remember how we talked about how it's important to consider implementation from the very early phases of developing programs. So to wrap up with some conclusions, comprehensive telehealth can provide greater support than in-person care and can improve glycemic control even in cases where in-person care is proved insufficient. So for a lot of our folks who are not responding well to in-person care, this can be a really valuable strategy. However, in order to facilitate successful implementation, interventions have to be designed and delivered in a system-specific manner that emphasizes feasibility, leverages available resources, And of course, many challenges remain, but the effectiveness and patient-centeredness of these approaches makes those problems worth taking on. And with that, I'll wrap up. Thank you so much.
Thank you. That was great. Next, we have Professor Jennifer Green, also from Duke University. She's a professor in the Division of Endocrinology and a faculty member of the Duke Clinical Research Institute. She's participated and led many, many clinical trials, almost all of them published in the New England Journal of Medicine, including this study that she'll tell us about today, multifactorial cardiovascular risk reduction to coordinate diabetes implementation example.
It was actually published in JAMA, so just for full disclosure. So thank you for being here this morning. I know it's early and there are a lot of competing sessions. And when we talk about implementation approaches or studies, it's not quite as sparkly and new, I think, as some of what you might hear about in the presentation of results on intervention trials of newer agents. But, the fact is, if we never translate what we've learned from these intervention studies into clinical care, then the results are really just of academic interest. So implementation is, I think, of utmost importance. I'm going to focus, these are my disclosures. I do have some. So I'm going to focus primarily, and my job was, as a part of this ensemble and writing the manuscript, was really to focus on implementation efforts to reduce the risks of diabetes-related complications. And for the sake of time today, I'm going to focus on the Coordinate Diabetes trial, which is a cluster randomized trial designed to improve the care of patients in cardiology clinics who have type 2 diabetes and established atherosclerotic cardiovascular disease. This is a trial that was designed and conducted through the Duke Clinical Research Institute. It was an investigator-initiated study that was sponsored by BI and Lilly. As background, we were fairly certain when we performed the analysis results that I show on this slide that the delivery of care to reduce cardiovascular risk in patients with type 2 diabetes and established ASCVD was fairly poor. And we set out to really quantify this as best we could. And these are data that we acquired from looking at records from over 150,000 commercially insured patients in the United States with type 2 diabetes and established ASCVD. And we were really interested in how they were being cared for in three specific respects. And that was, we wanted to see how many were on high-intensity statin, an ACE or ARB, or an SGLT2 inhibitor or GLP-1 receptor agonist, all of which were guideline-indicated interventions to reduce risk in this very high-risk population of individuals. And let me remind you that these are patients in the United States who have commercial insurance, so they have medication coverage, and that two of these interventions that we assessed are interventions and recommendations that have been in place for decades, and they're not expensive, right? So what we found was, if you look at the red bar, almost 40% of these individuals were on none of these three components of indicated care, which was really shocking. About 40% were on one of the three interventions, and 20% were on two. A very fortunate 2.7% were on all three of these recommended interventions. And as you might expect, the rate-limiting step here was the use of SGLT2 inhibitors or GLP-1 receptor agonists. These recommendations for care were newer, and of course, they're newer medications and more expensive. So when we designed the Coordinate Diabetes study, the objective was to test the impact of a clinic-level multifaceted intervention on the prescription of those same three key groups of evidence-based therapies in the cardiology clinic setting in the United States. Again, the trial was coordinated by the Duke Clinical Research Institute. We have the core study team listed on the left. We had a fantastic steering committee, and we did have a DSMB monitoring the safety of the study during its conduct. It's really a very simple study. Again, we enrolled cardiology clinics across the United States, and at those engaged sites, they enrolled their patients with type 2 diabetes and established ASCVD. Now, it's important to remember that the randomization was at the clinic level, so the clinics themselves were randomized either to our intervention or to usual care, and essentially the usual care group, they knew they were in this study, and we provided them with a copy of the recent guidelines that applied to the care of these individuals, but there was no additional intervention. We just followed their patients over time to see how they were cared for. On the other hand, the intervention sites received a multifaceted intervention that I'll describe a bit more fully on subsequent slides. This trial occurred, the pandemic occurred right in the middle of this study. Our original intent was to follow everyone every patient enrolled for a full 12 months. A very tiny proportion of individuals, because they were recruited very late in the game, were only followed for 6 months. But again, the primary outcome of the study was to see what proportion of patients were prescribed all three of those recommended therapies, high-intensity statin, ACE or ARB, or either a GLP-1 receptor agonist or SGLT2 inhibitor with cardiovascular outcomes benefit at the end of the day. The inclusion and exclusion criteria are really very straightforward. So again, people had to have a diagnosis of type 2 diabetes, and they needed to have established ASCVD in either the coronary, peripheral arterial, or cerebrovascular beds. So pretty basic. Patients, of course, could not be enrolled if they were already on all three of those indicated therapies. It wouldn't make sense. There's no room for improvement. And we also, because we were specifically interested about promoting use of the newer therapies, they could not be on an SGLT2 inhibitor or GLP-1 receptor agonist at baseline either. Patients could not be enrolled if they had an absolute contraindication to any of these three evidence-based therapies. And when I say an absolute contraindication, I don't mean that they had muscle pain on a statin in the past, and that's why they're not taking it. But if they'd had rhabdomyolysis on a statin, that would be an absolute indication. So we were very permissive about why they might not be on the medication. So this summarizes our multifaceted intervention, and you'll see some similarities here to the strategies that were described in some of the prior presentations. First, we assessed local practices and barriers in concert, of course, with the site team in that particular area. And, I'll digress a little bit from the slide. Before the pandemic, we would often send a small team out in person for the site initiation visit. And that usually was comprised of an endocrinologist, often me, a cardiologist, and an implementation specialist who is, for example, a nurse who has a lot of experience in implementation trials. And we would go out to these sites and talk about, first of all, why they weren't delivering this care to their patients, and we got their feedback about why they weren't doing it. And I will tell you, the knee-jerk reaction at every single site when you first start talking about it is, my patient can't access these drugs. That will always be the answer. The truth of the matter was, often they had just assumed that, and actually no steps had been taken to determine whether or not that was actually true. So we spent some time talking about access. We also provided them with some suggestions about how to overcome that issue. But there were really interesting things that I heard from the cardiologists that I would never have expected if we had not gone out there in person and just sort of hung around for hours and let them talk about what their barriers to care delivery were. And this trial was conducted at a time really before, for example, the heart failure trials with SGLT2 inhibitors were all completed. So the cardiologists were very unfamiliar and hesitant about using SGLT2 inhibitors and GLP-1 receptor agonists. And at more than one visit, a cardiologist told me that they didn't want to prescribe a diabetes medicine because then they assumed they would be responsible for all of the diabetes care. And that was very unexpected to me. So I was kind of there to provide a little bit of reassurance and tell them, no, it's going to be okay. And also to reinforce the fact that even though these were newer medicines that had some safety related issues they needed to know about and learn about, really, they prescribe far more dangerous medications and difficult to take medications on a daily basis. So a little bit of it was just kind of smoothing the path and having an endocrinologist tell them it was going to be all right. After we sat down with them, we helped them develop strategies to overcome their barriers to care, but they were very site specific. And for the most part, the sites and the site team came up with their own ideas. So this involved development of care pathways. We really emphasized the coordination of care between clinicians, and we recommended very strongly that they identify either an endocrinologist or a local diabetes care specialist who could be kind of their go-to to bounce questions off of if they had concerns about, for example, how to integrate a new medication into an existing regimen of diabetes care. We did provide them with some clinician education. We recorded lots of modules and developed educational tools for the clinicians. And then we also had some pretty snazzy educational materials for the participants, although we did not engage with them directly. For example, we had this really nice laminated placemat that talked about why they needed to be on these medicines, but it was very visually attractive and it had a little spot for them to put their medicines that they would take at that meal. So a little something for the participants as well. But then very importantly, during the study, we audited their performance, and we provided them with very easy to understand color-coded feedback about how they were delivering these three components of care to their enrolled participants. And this also included a comparison of how they were doing compared to the other intervention sites, because in particular, cardiologists are a little competitive and they like to do better than everyone else. So we exploited, I think, that personality aspect. The statistical analysis, the trial was initially powered at 90% to detect a 10% difference in the primary outcome. Again, the primary outcome being the proportion of individuals on all three therapies at their final follow-up. To take place at 46 clinics with 30 patients enrolled per clinic. But after the pandemic started, we did modify it a bit. We had 85% power, using 42 clinics with 25 patients per clinic afterwards. The primary and some secondary outcomes were analyzed using a mixed model for repeated measures, accounting for the clustering effect and adjustment for baseline factors, which I'll show you shortly as potential confounders. Even though we knew the trial was not designed to, or of long enough duration to collect enough actual clinical cardiovascular events for us to demonstrate an effect of the intervention on clinical hard outcomes, we did analyze those outcomes using a multivariable Cox proportional hazards model. These are where our sites were located across the United States. I noticed when, I think Matt showed where his locations were, something about kind of the upper Midwest, they tend to participate less in trials, so we have to figure out why that's happening. But we ultimately ended up having 43 sites enrolling participants, and there were a median of 24 participants enrolled per site. The baseline composite medication score, which could have been 0, 1, or 2, was 1.6 in the intervention group and 1.4 in the usual care group. These are the participant baseline characteristics based on whether or not they were at an intervention or a usual care site. And this probably looks different from baseline characteristics tables that you've seen elsewhere during this meeting. The patients differed, and that's because the sites themselves were randomized and not the participants. So you can see a little bit of, they were older participants, about little less than a third were women. We had fairly good representation of underrepresented minorities in the patient population, but again, some differences between the intervention and usual care populations. Primarily, they were patients who had coronary disease. Lesser proportions had cerebrovascular or peripheral arterial disease, and maybe a quarter or a little bit more had prior heart failure. All right, moving on to the results. I'm going to show you the results for the primary outcome. And again, remember that the primary outcome was not just being on one of these therapies. It was patients counted towards this primary outcome if they were on all three of high-intensity statin, ACE or ARB, or a GLP-1 receptor agonist or SGLT2 inhibitor at final follow-up. So here are the results from the usual care sites, and you can see that there was some improvement over time. They were aware of the guidelines. They knew that they were in a clinical trial, and their performance was being monitored by us, even though we weren't really helping them to do better. So we did see some increase in delivery of care. But in the intervention sites, what we saw was nearly a 40% increase in the proportion of individuals who were on all three of these indicated therapies. And if you're not used to looking at the results of implementation studies, this is actually considered to be a very highly significant difference. Many of these trials are conducted, and in fact, there's no difference at all. The unadjusted odds ratio for the accomplishment of or achievement of this primary outcome for the intervention groups compared to the usual care sites was 4.46, and then we adjusted that analysis for all of the baseline differences between the usual care and the intervention sites. Again, the odds ratio remained about 4.4 with a highly significant p-value. Now, you're thinking, what about the other 60%? I'll get to that. This is a really nice way to look about how the care changed for people throughout the context of, throughout the duration of the study. On the left-hand side are shown the usual care. I would describe this as sort of the flow of change in prescribing to these individuals during the conduct of the study. So usual care on the left, intervention results on the right. And what you see in green, represented in the green sort of bars, flowing bars, are patients whose care is being intensified. They're moving from, for example, being on one of these classes of drugs up to 2, for example, or they're moving from 2 to 3, or they're moving from 0 to 1. And I think you can visually appreciate that there's a lot more green going on in the intervention sites than there is in the usual care sites, although there's certainly some. The red bars are actually showing patients who had de-escalation of therapy during the conduct of the study, and there's far less of that in the intervention side than we see in the usual care group. When we look at some of the secondary outcomes, of course, we are interested in what happened to prescribing of the individual classes that comprise the primary outcome. And you can see very nicely here that the intervention was able to increase the prescribing of all of high-intensity statin, ACE or ARB or SGLT2 inhibitor or GLP-1 receptor agonist therapy, with actually the difference in performance by the intervention compared to usual care groups being most significant when it came to SGLT2 inhibitor or GLP-1 receptor agonist therapy. It's important to understand we were focused on changes in prescribing. So what we assessed at the end of the day was whether patients had a prescription for these medications. So we also had the sites get in touch with the patients themselves and say, are you actually taking this? And the good news is that somewhere between 96 to 98% of them confirmed that they were actually taking those prescribed medicines. We did assess and collect information about what happened to specific cardiovascular risk factors during the conduct of the study. I will say that our collection of some of these data were very significantly hindered by the pandemic and the fact that people were not getting their labs done on a regular basis or a far less regular basis than we had seen prior to the onset of the pandemic. So we have less than half of data for participants when it came to A1C or LDL cholesterol, a little bit more data collection for what happened with blood pressure. And you can see maybe some trends toward blood pressure being better in the intervention group, but not much change in A1C or LDL cholesterol. But I think we just have such incomplete data here, it's difficult to say much. Now, I had mentioned that we did do an assessment for the impact of our intervention on hard clinical events, and we needed to perform this. We needed to design the trial and this particular outcome with the events that could be easily ascertained from the medical record or talking with the patient directly. So this composite clinical outcome included all-cause mortality, hospitalization for MI, stroke, decompensated heart failure, or an urgent revascularization. So this is fairly broad, again, because we knew that these patients wouldn't have many, for example, deaths, MI, or strokes, but we were interested in assessing the impact of the intervention on, I would say, a sort of a broader burden of cardiovascular events. And you can see here, I mean, visually, you do see a difference, and the hazard ratio for this composite outcome in the intervention compared to usual care group was 0.79, but this was not a statistically significant difference. So of course, there are many limitations to the trial, more than I have on the slide, but these selected sites and patients might not be representative of the broader US or certainly the international population or locations of care elsewhere. We do know that because of the COVID pandemic, we really had to switch from in-person meetings and education and reinforcement to largely remote, so it was less personal, it was less intensive than we had originally designed. It could have been even more effective intervention if we'd been able to conduct the trial as we'd initially expected. However, in conclusion, this coordinated multifaceted intervention clearly increased prescription of 3 groups of evidence-based therapies in adults with type 2 diabetes and ASCVD. So we really were effective in moving the needle on how care was delivered in a variety of aspects to this high-risk group. Now, we don't have much information about how to accomplish this in clinical practice, but this is an example that we can use. And the next step, there's just one listed here. The cardiologists are very interested in how we can scale this up across cardiology practices across the US and elsewhere. But of course, this is an intervention that potentially could be reproduced in a variety of other care settings, such as primary care, endocrinology, et cetera, offices. And we're also interested in that 60% of people who were not on the 3 therapies at the end of the day, and perhaps some of those individuals would be better served by targeting their care in other settings, such as in the hospital. I'd like to let you know that there is a Coordinate Diabetes website where we actually provide all of the tools that we use during the trial. They're unbranded. They're very, as you can see here, they're really pretty visually attractive. You can listen to all of the modules that we recorded and provided to the site personnel, the site PIs in particular. So please take a look. It's all free for use. And the trial results, as I've mentioned, were published in JAMA last year. There are many more publications to come, and one abstract was presented earlier this year that actually showed that we increased the delivery of care of these aspects of care to a very diverse group of individuals, and essentially everyone benefited. All right, so thank you very much for your attention.
So one of the great barriers to implementation is time, and clearly our speakers have all been very enthusiastic about their topics. And Dr. Nissa Maruthar and I discussed yesterday that she might be left up here with not enough time to go through her presentation fully. Dr. Maruthar is an associate professor of medicine, epidemiology, and nursing at Johns Hopkins University. She's a general internist with a busy practice of a very prolific health services researcher, and one of the contributors to the ADA EST guidelines, specifically with regards to this implementation issue. And she'll talk to us about the final frontier in diabetes care, implementing research in real-world practice.
Thank you. I will get us through this in 7 minutes so we can have some conversation. My job is really just to provide place the prior presentations on implementation science approaches to improving diabetes care in context. How many of the folks in the audience actually provide care of some sort to patients? Okay, great. How many of you make decisions in your clinic that might impact patient care? You have a leadership position, you're a quality improvement person. Okay, good. All right, that's what we're going to focus on. Okay, so this is easy. This is what all you have to do for diabetes care. There are a bunch of things on here, and they're all evidence-based. The approaches, the outcomes that we're supposed to be working on, and you've heard 3 presentations on big trials or big studies that took a lot of resources to conduct. To help us figure out how do you take the research that shows effectiveness to real world practice. And I know a lot of us are already doing some of these things, but we still have a lot of evidence-based interventions. And I'm in primary care. We can identify 20 things each visit that aren't going the way that we'd like and don't satisfy what we know is the evidence. So how do we do this? Dr. Oldenburg already showed how do we bridge this gap? Implementation science. So that's what we've been talking about this morning. And I'm going to just highlight a few nuggets from the presentations we just heard so that when you guys do your evaluations for the ADA meeting, you can say, and when they ask you, is there something you're going to bring back to change your clinical practice? You can say yes. Please think of your examples as we go through this. All right. So again, one thing that we have to do, and this was shown with Coordinate, is we have to focus on improving multiple outcomes. Hemoglobin A1C is important, but it can't be the sole. We can't just, in clinical care, we can't just keep on focusing on one outcome. The next thing. So these studies have shown you that the patient-doctor encounter as the primary focus for improving diabetes outcomes has to change. And I specifically wrote patient to remind me for us to all think about our folks that we see with diabetes as people who are living with diabetes and spending 99.9999% of their time out of the clinic. And doctor. So we obviously think that doctors provide most of the care, but that's not true. And in addition, we don't have time and we're not trained to do a lot of these things. So it should be the person living with diabetes and all the healthcare providers. So what's going on in our clinical setting and how could we kind of utilize implementation approaches? So this is a figure that I made just to make us think about there's that visit that happens, and then there are all the things outside of the visit that are still in the clinical setting. And of course, there's the healthcare system that surrounds and dictates what's inside of it. And the examples we saw today show you that we have to be considering team-based care. We have to be making use of the access that we have to psychologists, to dietitians, to the specialists. That's what the I is, the ophthalmologist, pharmacists, nurses, and diabetes educators, CDCESs. And we have a lot of those resources. Everyone has some of these resources now in their practice. And the question is, how do you harness them? And we have to focus on not just the visit itself, but the inter-visit care. Tailoring to our local settings, that's easy for those of you that are practicing. Scaling and sustainability, the examples we showed today definitely show you that if you don't consider how you might go to the next step, you're not going to be able to have an impact. And then finally, and Dr. Oldenburg mentioned this specifically, we have to engage leadership. And many of you have raised your hands as leaders in this audience. You need to go to your leaders and talk about how things have to change, and we can't just keep on doing the same thing and expect it to be different. Obviously, outside of the clinical setting, people are living somewhere. They're in a community, and we have society and our policies. And again, the examples that we've seen today really do, raise the idea that we need to think about community-based approaches. We can't do everything inside the clinic. Telemedicine, remote patient monitoring, multi-level interventions. These are a bunch of levels. These aren't the perfect levels. There are lots of ways to look at levels, but we know that people are not just in one level all the time. And then finally, the intensity reach trade-off. So Dr. Oldenburg mentioned that as well. You know, we have a lot of efficacy studies, and we're not going to be able to do all of what they did. And the question is, you got to engage the trade-off and figure out, how to do it the best you can. And then advocacy, of course, so that we can change our healthcare system to accommodate all of these. Okay, so I'm going to go through a few examples and then show a couple slides and close up because we have 2 minutes. Okay, so when you're doing your next QI initiative, think about other outcomes. When you're talking about team-based care and utilizing your existing resources, make sure that you're not making everything provider-centric. So if you're starting a QI initiative, quality improvement initiative, empower the other staff in your clinic. And I mentioned nurses here, could be educators, it could be psychologists, it could be pharmacists. Who do you have in your practice and that you can engage? We need to increase inter-visit care. This is an example, again, and I'm just going to show a few of these and move past them because there are too many examples to go through right now. For those of you who are who watch the recording, you'll be able to see these. And the examples are almost over. Okay, so what am I talking about here? Continuous quality improvement. This is about what we do tomorrow, not what we do in a large funded study. This is about continuous quality improvement. And for those of us who trained more than 20 years ago, there are trainees that are required to do quality improvement who are trained in it, and we should be engaging them in addition, to the folks that are in leadership positions that may not have that. The focus is everything. It's not just looking at those long-term outcomes for the patient or for the people living with diabetes. It's operations. How can we make our work environment better? And you have to digest that this is going to be gradual. You're not going to have that many breakthrough interventions, but it's never done, and we have to keep on doing it. You need to define the problem. You have to have the data. You have to be willing to collect the data, have a goal, benchmark yourself, set a goal, and then it's going to be iterative. Their first intervention's never going to be the last one that's going to be effective. I put the PDSA model up here as one way to think about this. From a research perspective, we have to keep on doing our effectiveness studies in real-world settings when we can. Keep on enumerating how the local context has been incorporated, and then, of course, always be thinking about long-term scalability and sustainability. I'll leave you with these thoughts here on the considerations for translating evidence into practice. I already reviewed all of these. Please check out the paper that was published. And I want to close, obviously, thanking the audience, thanking the presenters, but then also I want to recognize Dr. Felicia Hill-Briggs, who helped me get into this area. The anniversary of her passing, for the first year is tomorrow. So thank you.
So there's time for a few questions. Thank you, Dr. Maruther, for providing that. Dr. Fisher, I see you approaching the first microphone.
Thank you. Terrific symposium. I just wanted to comment, I was struck that each of the presenters talked about tailoring and adaptability. Dr. Crowley put it explicitly that you had the core components and I think the adaptable components. The last presentation, or the third presentation, had local clinical teams developing pathways. And I know in Kerala, Brian and his colleagues did a lot of local adaptation of core approaches. I think this is a really critical conceptual issue for implementation, and it really runs against many of the traditions of standardization and efficacy-based interventions. So I was just going to invite anybody to comment if they'd like, but bravo.
Yes.
No, I think that's true. I think if we had just shown up at these locations and just laid down the law, right, it wouldn't have gone over very well. People would have been resentful and it wouldn't have worked for them. So we served as a guide for them to really figure out at least those initial approaches on their own.
Next.
Hi, my name is Mingding from UNC, so Chapel Hill, and I have a question for the second speaker about the telehouse. So I wonder if the effect size of the intervention differs so by age, such as how about the effect size among middle-aged people and older-aged people? Because I was wondering how well the older-aged people respond to telehouse. Thank you.
Yeah, that's a great question, and age is a moderator of effect in interventions like these for sure. It's not just age, though. When we look at things that moderate the effect size in our programs, it's everything from age to starting A1C. The more poorly controlled someone is to begin with, the more room they have to improve. So you tend to see larger effect sizes. Of course, if you then cross a line where someone's so poorly controlled that it implies there's too many competing demands in their life, they may not respond at all. For our program, I think we have good evidence that older folks tend to respond well, for sure. but the average age for this like persistently uncontrolled group we look at tends to be younger than you would think, usually in the 50s.
Thank you. Next.
Frederick Persson from Steno Diabetes Center, Copenhagen. Thanks for a very nice and very impressive symposium. For Dr. Crowley, I'm wondering, when you move from inpatient consultations to telehealth, for example, the comprehensive telehealth approach that you displayed us, do you then plan, or I assume that you do some special training, for example, the nurses that are going to go for that different approach? Could you explain in a few sentences what to do with changing the identity of the health provider like that?
Sure. In our VA studies, this is easy because the VA has built infrastructure to facilitate delivery of telehealth care all around the country. So it actually requires very minimal training in that setting. When we do this kind of work at Duke, we do have to train our nurses to both deliver telehealth care and then sometimes to understand kind of the nuances of diabetes care sufficiently. So yeah, no question, that's a really important part of the picture, and it will vary a lot from context to context how much training will have to be done. Thank you.
I'm Hamid Hassan in Dubai. Question to Dr. Green. Excellent work, but why did the KPIs of LDL and blood pressure and HbA1c did not change very much between the intervention and the other group?
Well, we had such incomplete data collection for example, hemoglobin A1C and LDL cholesterol. I think it's very difficult to understand whether or not we had a meaningful impact during the pandemic and around the time that many people were concluding the study. People were less likely to get their labs drawn, less likely to see their doctors, to have their essentially usual diabetes care performed. And so it's difficult to know. But in any event, we know that these are therapies that are going to improve outcomes. I don't think we have to re-demonstrate that by demonstrating an effect on intermediate or mediators of cardiovascular risk. We know these drugs work and people should be on them. But you're right. We couldn't see a significant difference in those particular surrogate outcomes.
Jonathan Shaw from the Baker Institute, Melbourne, Australia. There's a parallel session on implementation in the trade hall. It goes on for a lot longer than this session and is much better funded. I just wonder what the panelists think about the difference in the style and the effectiveness of that kind of intervention and implementation than we do.
I think the thing that you're trying to raise is in the trade hall. Functionally, they are engaging in their version of implementation science, and what do the panelists think about that? I might have Nissa take a shot at that. As the general internist, the cleaner end of the spectrum.
I think that it's still where the work that's been talked about today is really where the rubber meets the road, and that is the difference. There is going to be advertisement, et cetera, of the interventions, and some of that does work its way in. But I think that what is being shown by the data, some of the data that have been presented today on lack of uptake of diabetes prevention interventions, lack of people being on medications that have been known to be helpful and are now inexpensive for 25 years, shows that even the trade hall approach is not really working anyway.
I might just make one additional comment, Jonathan, and I won't reflect on the situation here in the US, but one of the things we've found in working more in low middle income countries like India is the environment in one respect is, there's not other competitors for the implementation or driving the implementation to the same extent. So we've found, for example, the last couple of years following the sort of pandemic in India, that the state governments have really been driving a lot of change in systems because they realise that they have to develop new approaches to deal with people with hypertension and diabetes in the community, and they can't persist with the traditional system of all these people coming to hospitals, which are just really suffering under the pressure. So that pull from health departments has been and their leadership has been very important, I think, for implementation and driving that.
So, Peter, I'm going to skip you because the people in the back have been staying there longer. Why don't you just come to the front microphone?
Not clear.
Scurry.
Scurry. Please scurry.
Hi, this is really exciting. And so, of course, I'm jumping to implementation in my system. And I'm wondering, in fee-for-service world, we do have E&M codes for televisits. And so other clinicians like APCs or APPs. And I'm just wondering if you've thought through, you're using in the VA, Dr. Crowley, the RN to pharmacy model. Have there's been any thought or implementation outside of the VM system that you're aware of that uses advanced practice clinicians who can bill that way? And then to follow up with that, awesome website with all the details, Dr. Green. I'm wondering if there's any access to your implementation and models that you used for training the RNs at the VA.
I can go first. So thank you for the question.
We have about 30 seconds, so brief.
Let me wax philosophical for a minute. Just briefly, the program that we use is set up to allow anyone to do the medication manager. I was the first medication manager, and I'm an endocrinologist, so it doesn't have to be a clinical pharmacist. That tends to be what a lot of our partners choose as their interventionist, but it can be anything.
Great.
And Jennifer?
Oh, yes, all those tools are available online. It wasn't really very sophisticated training that we provided to the sites. Again, we were just sort of guiding them to come up with their own solutions that they found to be a best fit.
Great. Thank you so much.
So technically we're out of time, but very quick.
Okay. Nita Lee-Tirpong, University of Chicago. I'm a general internist. Big picture question. Constantly, primary care, cardiology, we all are super busy. And it's always a matter of priorities in clinical practice. And so I love cost effectiveness analyses, like they're great and I do them. But the question is cost savings is really the question, right? Because it's all about, like, if you do more and it costs more money, where is that money coming from? So I have a question for any of you. How do you argue that this is more important than all the other things we're asked to do for preventive care? I believe diabetes is important. I'm here, but you know that there are other problems on the table.
Well, one of the things, the VA is very good, I think, about justifying investments that are going to improve long-term outcomes. You see less of that sort of perspective in the fee-for-service environment. But we know that it's important that we introduce interventions to reduce cardiovascular risk in high-risk individuals, because eventually what you're doing is you're reducing their risk of death, hospitalization for MI or heart failure, et cetera. Now, in implementation studies, it can be a little bit difficult to demonstrate cost effectiveness because we don't follow people generally long enough to demonstrate that. But it really is a study of how we can better do what we're supposed to be doing already. And we're just trying to make it a little bit easier.
Can I comment on that?
No.
No.
We don't have enough time. Peter, are you going to?
Yeah.
You can, all right. I mean, we're 2 minutes. Go ahead.
No, I'll withdraw that.
All right. Well, we're 3 minutes overdue, and the next group is going to come, and we need to go to the next session. I want to thank the panelists for a great talk.